Thank you for joining us. Today I will be providing a case-based review of relapsed refractory lymphoma. My employer is the University of Colorado and I have no conflicts of interest. The learning objectives for today are to understand the role of radiation therapy in relapsed refractory diffuse large B-cell lymphoma, Hodgkin lymphoma, and follicular lymphoma. I would like to start with the caveat that only limited, non-randomized data are available regarding the role of radiation therapy in the setting of relapsed refractory lymphoma. Data are predominantly retrospective, and there is heterogeneity in radiation volumes and doses, as well as potential selection biases. However, data do support a role for radiation therapy in relapsed refractory lymphoma. I would like to bring your attention to the ILROG Guidelines, which are an excellent resource. There are guidelines on both relapsed refractory diffuse large B-cell lymphoma and relapsed refractory Hodgkin lymphoma, which provide clear recommendations for various clinical scenarios. The first case that I would like to discuss today is of relapsed refractory diffuse large B-cell lymphoma. The patient is a 55-year-old man who presented with an abdominal mass, drenching night sweats, and a 20-pound weight loss in the previous 3 months. A CT scan showed a 17-centimeter retroperitoneal mass with adjacent smaller lymphadenopathy. A biopsy of the bulky mass showed high-grade B-cell lymphoma with MYC, BCL2, and BCL6 rearrangements by FISH, consistent with triple-hit lymphoma. A PET confirmed the presence of a bulky retroperitoneal mass and smaller adenopathy above and below the diaphragm. A bone marrow biopsy was positive for B-cell lymphoma, and LP was negative for disease. So this patient was diagnosed with stage 4BX high-grade B-cell lymphoma. He had triple-hit lymphoma based on the rearrangements in MYC, BCL2, and BCL6 by FISH. Triple-hit lymphoma is associated with a poor prognosis. Therefore, he was treated with R-EPOCH chemotherapy rather than R-CHOP to intensify his systemic regimen. After 6 cycles of R-EPOCH, there was persistent FDG avidity of the retroperitoneal mass. A biopsy confirmed the presence of primary refractory disease. The patient was treated with salvage rice chemotherapy, followed by autologous stem cell transplant with high-dose R-beam. After his transplant, his PET was assigned a Deauville score of 3, consistent with a complete metabolic response. There was a persistent retroperitoneal soft tissue mass at the site of the initially bulky disease. As background, among patients with diffuse large B-cell lymphoma treated with R-CHOP, around 10 to 15% have primary refractory disease, and an additional 20 to 25% develop relapse after an initial response to chemotherapy. Transplant-eligible patients are those with chemosensitive disease who are fit for transplant. In these patients, the standard of care is salvage chemotherapy, followed by high-dose chemotherapy with autologous stem cell transplant. In these patients, high-dose chemotherapy with autologous stem cell transplant provides a progression-free and overall survival benefit compared with conventional chemotherapy as established by the PARMA trial. So what is the rationale for radiation therapy to be used as a part of salvage? Relapses after autologous stem cell transplant often involve the initial relapsed refractory sites, even after a complete response to salvage chemotherapy. In one study of patients treated with salvage autologous stem cell transplant, 75% of cases of progression after transplant involved primarily the original site of relapsed refractory disease. This finding supports incorporation of radiation therapy as part of salvage to improve local control. The PARMA trial, which we just discussed, used consolidative radiation therapy to sites of bulky relapsed refractory disease, defined as greater than 5 centimeters. With this approach, there were fewer relapses among patients who received radiation therapy, despite the presence of bulky disease in this group. This difference was not statistically significant, but the study was not powered to address this question. When should peri-transplant radiation therapy be used for patients with DLBCL? Patients with localized relapsed refractory disease that can be encompassed in a reasonable radiation field should be considered for radiation as a part of the salvage regimen. In patients with a more disseminated relapse, radiation to selected sites can also serve an important role. For example, sites that were bulky at relapse might benefit from radiation. In previous studies, such as the PARMA trial, 5 centimeters was used as a cutoff to define bulk in this setting. Local regionally confined sites with an incomplete response to salvage chemotherapy should also be considered for radiation therapy. Bony sites of disease may be treated with radiation. Extrapolating data from the subgroup analysis of the MINT and Recover 60 trials showing that radiation significantly improved outcomes for skeletal DLBCL in the upfront setting. Additionally, radiation may be considered for sites in which local control is especially critical, such as relapse disease causing or threatening cord, SVC, or airway compression. When should radiation be given with respect to transplant? There are advantages and disadvantages of giving radiation therapy before and after transplant. With respect to pre-transplant radiation therapy, one advantage is that it may cytoreduce residual active disease. Furthermore, it may convert a partial response to a complete response prior to transplant, and outcomes are improved for patients who go into transplant without active disease. Disadvantages of pre-transplant radiation therapy are that it may increase the risk of toxicity during transplant, such as pneumonitis, veno-occlusive disease, dermatitis, mucositis, or enteritis, depending upon the site that was irradiated. Also, pre-transplant radiation therapy may delay the transplant, and there is the risk of progression outside of the radiation field during treatment. One may consider twice-daily treatments to reduce the delay. Lastly, pre-transplant radiation may interfere with harvesting stem cells if there is a significant volume of bone marrow in the radiation field, so consideration should be given to harvesting cells prior to radiation. Advantages of post-transplant radiation therapy include the potential for less toxicity during transplant. Also, the final radiation therapy dose and volume may be based on overall response to systemic therapy, so doses may be lower and volumes may be smaller. Disadvantages of post-transplant radiation therapy are that it exposes the stem cells to radiation, so it may cause prolonged cytopenias, especially if a large volume of bone marrow is in the radiation field. Also, it is possible that the window for radiation therapy delivery may be missed if the patient's recovery from transplant is prolonged. In terms of radiation dose and volume, after a complete metabolic response, defined as a Deauville 1 to 3, a dose of 30 to 36 gray at 1.5 to 2 gray per fraction is recommended. Involved site radiation therapy should be used to target the previous relapsed refractory disease. Adjacent disease that responded to first-line chemotherapy may be included if its inclusion will not significantly increase toxicity. Returning to our case, here you see an image of the patient's pre-chemotherapy PET-CT and the simulation CT that was performed after transplant. You can see the persistent soft tissue remnant on the simulation CT. At the time of simulation, I got a 4D CT scan, which showed that there was no respiratory motion of the mass. When I'm treating these patients, I like to contour the pre-chemotherapy site of disease for reference, as shown in blue. But please note that it is not necessary to treat the bowel that was displaced by tumor and has now returned to its normal position. Here are the final target volumes for this case. The CTV was the residual soft tissue remnant that may contain residual microscopic lymphoma. I did not create an ITV because there was no respiratory motion on the 4D CT scan. The PTV was a 7 millimeter expansion. The patient was treated to 36 gray in 18 fractions using daily cone beam CT to align to the soft tissue mass. What if the disease had not responded completely to salvage systemic therapy? Gross disease, defined as a Deauville 4 or 5, should be treated to around 40 to 50 gray. In some cases, it may be preferable to treat adjacent sites that responded to chemotherapy to around 36 gray and to deliver a boost to the refractory disease. For patients with chemorefractory disease, consider pre-transplant radiation therapy to cytoreduce and potentially convert to a complete response prior to stem cell transplant. As mentioned previously, one may consider harvesting stem cells before radiation therapy, particularly if a large volume of bone marrow is in the radiation field, so radiation does not affect adequate collection of cells. Also, it's possible to minimize the delay before transplant by treating twice daily. For example, researchers from Memorial Sloan Kettering have published their experience treating to a total dose of 30 gray at 1.5 gray per fraction BID. If the patient will be getting radiation therapy as their only treatment, has local regionally confined disease, and is being treated with curative intent, a dose of 45 to 50 gray or more may be used. If the disease responds favorably to radiation therapy, consider adaptive replanning midway through treatment. If the intent is palliative, a dose of 8 to 30 gray is reasonable. What if this were Hodgkin lymphoma instead of DLBCL? Disease would be more likely to be above the diaphragm, and the patient would be more likely to be younger, as the median age is around 70 for diffuse large B-cell lymphoma compared to 39 for Hodgkin lymphoma, which has a bimodal age distribution. Also, there are minor differences in systemic therapy. For example, frontline therapy is often R-CHOP for DLBCL and ABVD for Hodgkin lymphoma. There are many similarities in the management of relapsed refractory DLBCL and Hodgkin lymphoma. For both, if the patient is transplant eligible, the standard of care is salvage chemotherapy, then high-dose chemotherapy with autologous stem cell transplant. Also, relapses after autologous stem cell transplant often involve the initial relapsed refractory sites, suggesting a role for radiation therapy to improve local control. Other similarities include peri-transplant radiation indications and doses. Indications for peri-transplant radiation therapy in the setting of relapsed refractory Hodgkin's include localized disease that can be encompassed in a reasonable radiation field, or in the setting of disseminated relapsed or refractory disease, radiation to selected sites may be beneficial. For example, sites that are bulky at relapse may be treated with radiation, and a size of 5 centimeters at the time of relapse has been shown to be prognostic. Also, sites with an incomplete response to salvage chemotherapy, or in which local control is especially critical, may be treated with radiation therapy. Typical doses are 30 to 36 gray for a Deauville 1 to 3 and 40 to 45 gray for a Deauville 4 to 5, potentially with a simultaneous integrated boost to treat chemosensitive sites to a lower dose and chemorefractory sites to a higher dose. If radiation therapy will be the only treatment, a dose of 36 to 45 gray is reasonable if the intent is curative. A dose of 8 to 30 gray is reasonable if the intent is palliative. One difference between DLBCL and Hodgkin lymphoma is that there are more data regarding successful salvage with radiation therapy alone in Hodgkin lymphoma. Systemic therapy should be given as the standard of care, but radiation alone may be considered if the patient cannot get systemic therapy. In this case, the dose should be 36 to 45 gray, and the treatment volume is involved site radiation at a minimum, but larger fields may be considered when systemic therapy is not being used to address microscopic disease. So here's a case of relapsed refractory Hodgkin lymphoma. This was a 17-year-old male who presented with progressive shortness of breath and fevers and night sweats. A chest CT showed a bulky upper mediastinal mass, a left upper lobe mass with central cavitation, and bilateral small pulmonary nodules. A biopsy of the mediastinal mass showed classical Hodgkin lymphoma, nodular sclerosis subtype. A PET CT confirmed the presence of supraclavicular and mediastinal adenopathy, a left upper lobe mass, and bilateral pulmonary nodules. A bone marrow biopsy was negative for disease. Based on this workup, the patient had stage 4B Hodgkin lymphoma. He was treated with adriamycin, vinblastine, dacarbazine, and brentuximab vedotin. After 6 cycles, he was found to have biopsy-proven refractory disease of the superior mediastinum with a mass measuring 6.5 centimeters. His other disease had responded completely. He was treated with salvage gemcitabine, ifosfamide, and vinorelbine, followed by autologous stem cell transplant with gemcitabine, busulfan, and melphalan. His post-transplant PET showed a complete metabolic response with a Deauville score of 2. Here you see an image of the patient's pre-chemotherapy PET-CT and the simulation CT that was performed after transplant. As with the prior case, I contoured the pre-chemotherapy site of disease for reference, as shown in pink. However, it is not necessary to treat the lung that was displaced by tumor and has now returned to its normal position. Here you see the CTV, shown in red, which is the residual soft tissue remnant at the prior site of mediastinal disease. The PTV was a 5 millimeter expansion. This patient was treated with a breath hold technique. Deep inspiration breath hold can help to reduce normal tissue dose for patients with mediastinal disease. Here you see the breath hold and free breathing scans that were obtained for this patient at the time of his simulation. Deep inspiration breath hold pulls the heart inferiorly away from the site of disease and increases the lung volumes. These changes in anatomy help to reduce dose to the heart and lungs. This technique is a cost-effective and simple method to reduce the risk of adverse effects from radiation therapy for mediastinal Hodgkin lymphoma. This patient was treated to a total dose of 30 gray in 15 fractions using a daily cone beam CT to align to the mediastinum. What if we were considering follicular lymphoma instead of DLBCL or Hodgkin lymphoma? Here the treatment paradigm is different. Follicular lymphoma tends to be indolent. There are a range of management options for relapsed refractory disease. If the patient has a low disease burden and is asymptomatic, observation is one reasonable strategy. Radiation should be considered for locally confined disease. If the patient has a high disease burden and/or symptoms, multiple options are available, including an anti-CD20 monoclonal antibody, chemotherapy, involved site radiation therapy, and/or allogeneic stem cell transplant. From a radiation perspective, follicular lymphoma is exquisitely radiosensitive in both the upfront and relapsed refractory setting. Prospective randomized trials in the UK compared 24 gray to 40 gray and found equivalent disease control. They went on to compare 4 gray to 24 gray and found a reduction in disease control with the lower dose, but response rates were still quite good, with an approximately 50% CR and 30% PR rate at 12 weeks. Therefore, both 24 gray and 4 gray are useful in the setting of relapsed refractory follicular lymphoma. For localized disease, one may consider definitive radiation therapy with 24 gray. In the setting of advanced disease, one may consider palliative radiation therapy with 24 gray when durable local control is critical, for example in the setting of cord compression or organ compromise, or 4 gray when durable local control is less critical and/or there is concern for toxicity with 24 gray. Here is a case of relapsed refractory follicular lymphoma. The patient was a 66-year-old woman who presented with an axillary mass and fatigue. She was found to be pancytopenic and diagnosed with stage 4, grade 1 follicular lymphoma with adenopathy above and below the diaphragm and bone marrow involvement. Disease relapsed after several lines of therapy, including bendamustine and rituximab, R-CHOP, and lenalidomide and obinutuzumab. She presented to the emergency room with proptosis, and imaging revealed orbital involvement by her follicular lymphoma. This patient was treated with palliative radiation therapy to a total dose of 4 gray and 2 fractions. Because it is a low dose and the mass was infiltrative and filled most of the orbit, I chose to treat the entire orbit using a wedge pair. The patient experienced excellent palliation of her symptoms. In conclusion, in the setting of relapsed refractory diffuse large B-cell lymphoma and Hodgkin lymphoma, the standard of care is salvage autologous stem cell transplant for transplant-eligible patients. Radiation therapy may be used as part of the salvage regimen to enhance local control at sites that are at the highest risk of subsequent relapse. Doses in the range of 30 to 45 gray are appropriate for definitive therapy, depending on the other therapy given and the disease response. Doses of around 8 to 30 gray are appropriate for palliation. For relapsed refractory follicular lymphoma, radiation therapy may be used to provide local control or palliation. 24 gray is appropriate when the primary goal is durable local control. 4 gray is appropriate for palliation. So we can conclude that peri-transplant radiation therapy may contribute to local control in patients with chemosensitive DLBCL and Hodgkin lymphoma. Radiation provides an opportunity for curative treatment in a subset of patients with localized relapsed refractory lymphoma. Radiation can provide effective local palliation. And as a future direction, as novel agents are adopted for the treatment of relapsed and refractory lymphoma, the role of radiation therapy continues to evolve.